Well, hello everyone. Hope you all had a good weekend. Okay, so today we're going to talk about anaphylaxis, so mostly case-based. So for a couple of these, we can unmute when there's some questions. Y'all can chime in and we'll talk about it. If I can see the slides, okay? Okay. So first case, a 16-year-old boy was out mowing his lawn and was stung by some insects that flew out of the ground. Within about 10 minutes, he developed urticaria, facial swelling, dizziness, shortness of breath. EMS came and his blood pressure was low and he was tachycardic. So if you're out there and you've got your medicine kit all with you, what's the first thing that you give here? You give some Benadryl or diphenhydramine, put them on oxygen, give them epinephrine, or try albuterol for shortness of breath. So if I can unmute for a second and chime in, and what's your one treatment?
Epi.
Epinephrine, exactly. So there's no other appropriate treatment, and nothing else is really that effective for this. So intramuscular epinephrine. And how much do you give? So one of the few doses.
Mg per kg.
Yep. So it's
1,000
doses that you should actually memorize, because never a time to look it up. So it's 0.01 milligrams per kilogram up to 0.3 to 0.5 milligrams. In Europe, they give 0.5 a lot. For big adults, I'll give 0.5. Normally, I give 0.3, and that's what's in an EpiPen or self-injectable epinephrine. Now, I think about 12 years ago here, someone was given, it was a teenage girl, and she was given 0.01 mg per kg, but she weighed 60 kilograms, and she got 6 milligrams, and she did have she had an adverse effect. She had a subendocardial myocardial infarction, but it's pretty rare though. Epinephrine is very safe as long as you don't give 6 milligrams. But just know that it's 0.01 mg per kg up to about 0.3 for kids. So anaphylaxis, it's a pretty broad definition: a serious, life-threatening generalized or systemic reaction that's hypersensitivity mediated. And the other, the World Allergy Organization definition is a serious allergic reaction that is rapid in onset and might cause death. So pretty vague, but it's meant to be vague because it can have pretty wide ranging triggers and symptoms. So with anaphylaxis, you can have the life-threatening symptoms of cardiovascular collapse or shock. Most people either have some kind of skin or GI findings. So you can have hives, you can have abdominal cramping, vomiting, diarrhea, very common in kids. And some kids only throw up. You know, they get food allergy, they throw up, and they feel better. But most of the time, you see either some erythema, some urticaria, or some edema. Also life-threatening, you can have laryngeal edema and severe bronchospasm. In kids with food allergy, the most common cause of death is probably going to be a severe asthma exacerbation or airway obstruction. And in females, you can even have uterine contraction have been reported. So these are typical hives or urticarial wheals. They're transient, they come and go, they move around. With food allergy or really any anaphylaxis, they should come on quickly, like within minutes to an hour or two of the agent, but they shouldn't last for days or weeks. When you see a patient in the emergency room that has had hives for like a week straight, that's not going to be anaphylaxis. That's going to be something more like a acute or chronic urticaria. And this is angioedema. See the little guy on the left has got urticaria over his chest, along with swelling of his lips or angioedema. And then the next picture is severe angioedema of the face with laryngeal angioedema requiring intubation. So the diagnosis of anaphylaxis It's very likely when you have an acute sudden onset of either urticaria angioedema, like itching, flushing, hives, um, or mucosal swelling, especially the lips, the tongue, and either respiratory symptoms or low blood pressure. So if you do that combination, it's probably anaphylaxis. Or if there's a likely allergen and they have skin, GI, respiratory symptoms, GI symptoms, it's likely anaphylaxis. Or if they have a known allergen, say peanut or penicillin, and they have a sudden drop in blood pressure, that's probably anaphylaxis as well. But oftentimes it can be difficult to really determine what is the trigger for anaphylaxis. And sometimes it can be helpful getting a tryptase level. So tryptase is released by mast cells. It has to be checked pretty quickly, like within 3 hours. After that, it goes back to normal levels. And oftentimes for food allergy reactions, the tryptase can be normal. So a normal tryptase does not exclude anaphylaxis. So here's some of the common cause of anaphylaxis. Outpatient foods are number one, and the vast majority of food allergy are caused by, in kids, milk, egg, peanut, and then as they start eating them, tree nuts, fish, shellfish, and then to a lesser extent, soybean and wheat. And then sesame is kind of the new up and coming food allergen. They're probably gonna make sesame be one of the mandatory labeled allergens in the US pretty soon here. In Europe, they see a lot more anaphylaxis to fruits than we do, like especially on the Mediterranean, they have a lot of peach allergy for some reason. In adults, shellfish is number one. The number one cause of outpatient anaphylaxis that lead to death is actually stinging insects, the Hymenoptera. So fire ants, bees, wasps, hornets, yellow jackets. Number one cause of anaphylaxis in general is medications, especially in the hospital, and it's a leading cause of death overall. Beta-lactams are a big one. NSAIDs. NSAIDs are usually not IgE dependent. It's usually caused by a shifting of leukotrienes, but some patients can have an allergy just to one NSAID. We're seeing a lot of biologics now, and several of those can cause anaphylaxis as well. Latex, we don't see much latex allergy anymore because no one wears latex gloves in the hospital. Occupational can be latex, can be bees. Seminal fluid, kind of rare, but I've got a couple patients who can have either local or systemic allergic reaction to seminal fluid. Occasionally air allergens. It's pretty rare to have anaphylaxis to like pollen or an animal, but I have seen a case of a deer. Someone stuck a deer in the back seat of the car and the child had anaphylaxis. And then radio contrast is a common one. Again, it's usually not IgE dependent. It's usually an IgE independent mechanism, radio contrast. When I was a student, they used to call it anaphylaxis, anaphylactoid, but now we just say it's anaphylaxis, and it's either IgE dependent, which means you have preformed Ig in the mast cells, or it's Ig independent, which can be due to direct mast cell release or complement fixation or leukotriene shifts in NSAIDs. You can also have these direct mast cell activations, things like exercise, alcohol, heat, narcotics, and medications. And we're seeing more and more that some patients have to have a cofactor where they have to have anaphylaxis. They have their food, plus they have exercise or alcohol or take some ibuprofen. And we're seeing this more and more with peanut immunotherapy. After you get your peanut immunotherapy dose, you're supposed to kind of relax for 3 hours, because we're seeing kids who go exercise or got a hot shower after the immunotherapy dose can have a reaction to it when normally they tolerate it fine. And just, a couple weeks ago, I saw a guy up at Clemson. He was out and normally he does okay, but he had the combination. He was drinking all day at a tailgate. He took some naproxen for back pain and he was playing touch football and he had an anaphylactic reaction. So he has these several triggers can combine to make it worse. So what causes anaphylaxis? We mentioned earlier the foods, the main cause of outpatient. Main cause of inpatient is drugs, but idiopathic is a big component. A lot of patients with anaphylaxis, we just never figure out what caused it. Also, you can get exercise-induced anaphylaxis, which can either be on its own, or the exercise can potentiate another trigger like food. So some patients you'll see, they can eat peanut or shrimp or wheat normally, but then when they exercise, in addition to eating the food within a few hours, they have anaphylaxis. And we're not sure what the mechanism of that is. 2009, 10 years ago, about 30,000 cases of anaphylaxis treated in hospitals and emergency rooms. That number is actually going up. We're not sure why. And of those, about 30 deaths, so about 0.3%. So not really that fatal in terms of overall numbers, but most of these patients are young and healthy. And these are a little bit low numbers. Usually there's about 40 to 50 deaths just from insect allergens per year. And then this is outpatient here. This is not taking into account inpatients with medications. And an older hospitalized patient is much more likely to die from a reaction than a young healthy patient. But we think in general about 200 people die from anaphylaxis a year. Again, probably not counting in all those inpatient drug errors and the drug reactions. Okay, so treatment, you start if they're having a cardiovascular compromise or respiratory distress, ABCs, airway, breathing, circulation. Remove the offending agent. If they're on an IV drip of a drug, stop the drip. If we think they're getting stung by insects, make sure you get the insects off. If it's a bee sting, you can flick the triggers out, call for help. Epinephrine is the only real treatment. And when you give the epinephrine, as we'll see in a minute, you got to give it in the thigh. So you got to give it in the big muscle. Put the patient on the ground or on a stable bed. Put their legs up in Trendelenburg, so you get some blood pressure, blood flow to the head and heart. If their blood pressure is low, IV fluids. If they're not oxygenating well, give them oxygen. But epinephrine, again, is the drug. So 0.01 mg per kg. This should be 0.3 to 0.5 milligrams. You give it in the lateral thigh. You can give it through pants if you need to, but a lot of times I'll try to pull the pants down if I can. For IM administration, even the 1 to 1,000 concentration, and now we say it's 1 milligram per ml. So in an EpiPen, there's 0.3 mLs, which is 0.3 milligrams. And people always ask, how much can you give? When can you repeat it? You just give enough. I give it every 5 to 10 to 15 minutes until their symptoms are controlled. Or if not, you need to get them into an intensive care situation with an epinephrine drip. Cardiogenic shock, you can use a 1 to 10,000 dilution. So when you're in the unit and you say, give an AMPA epi, that's 1 to 10,000. So 10 mLs is going to be 1 milligram. But again, for the IM, we're giving a 10-fold stronger concentration. A good board question, when people are on a beta blocker, in addition to epinephrine, you may give them glucagon, because the thought is the beta blocker can block the beta adrenergic effect of the epinephrine. So these are all second-line therapies. It always drives me crazy. People go to the emergency room and they get, diphenhydramine, they get famotidine, they get albuterol. That's all kind of wasted. So for the itching and the redness and the mild swelling, sure, you can give an antihistamine. You can give diphenhydramine, or actually I give cetirizine. It's my favorite. I just give them 5 to 10 of cetirizine, or up to 20 milligrams if they're older. And actually they now have an IV cetirizine we can give as well, but I haven't used it yet. If they have asthma or wheezing, give a beta agonist, but again, no substitute for epinephrine. If they're wheezing due to a food allergy or any allergen, epinephrine. Glucocorticoids, everyone gives it, like you go to the emergency room, they give you steroids. It may actually worsen outcomes. We think there's actually very little role for steroids in anaphylaxis now. And when I was like a student or resident, we give 3 days of prednisone and 3 days of Zyrtec after a reaction. There's no data that's helpful. So when I treat anaphylaxis now, I give antihistamines for mild. For anything severe, even moderate severe, I give epinephrine with the antihistamine, and I may not even give steroids anymore. And I don't even waste my time with the ranitidine. There's really no evidence for its efficacy. the problem is that you send them to the emergency room, they're like, why didn't they give them steroids? And they pump them full of methylprednisolone and other stuff. But again, there's very little data those help. Okay, so long-term care, once you diagnose their allergen, hopefully patients have a personal allergy action plan, and all children should have one of these plans at school, whether it's for a drug or an insect sting or whatever their anaphylaxis is. You should carry 2 epinephrine auto-injectors. They come in a 2-pack because you may need a second dose. It's not because you can have one of the pens at school, one at home. I give everybody 2 2-packs, so 2 at home, 2 at school. Ideally, a medical alert bracelet. For kids, they have cool little bracelets that can have, you can like stick in like the peanut or whatever allergen they have. And then the big thing for food is like telling patients, watch out for bakeries, watch out for Asian food, watch out for ice cream parlors. Always ask the server, about food allergy. If they're not sure, ask the manager or the chef. So most patients are going to have reactions every couple of years, but you can really do these things to help mitigate that. Okay, so insect venom. Our patient was stung by an insect that came out of the ground, so it's probably yellow jacket. Insect venom, actually, case for case, is more fatal than food allergy. So the Hymenoptera, again, is honeybee, wasp, yellow jacket, hornets, and then fire ants. So it's a fire ant, pretty obvious. We see these all the time. And it's actually the sting that gets you, not the bite. They hold on with their mouth, they sting with their abdomen. And this is the telltale sign of a fire ant sting, is the next day you have a sterile pseudopustule. Don't pop these, it's not infected, just leave them alone. What's this? No?
Honeybee?
Yes, and why is he fuzzy?
Pollen carrying.
Yes, so he's the perfect pollen carrier. Levels of pollen for airborne allergens are magnitudes higher than for flowers. It's because butterflies and honeybees are such good carriers of pollen. That's why when honeybees, if they have a decline, it really is going to hurt our food industry. And what are these guys here? So
White-faced hornet.
Yeah, so nice white face on this guy and the yellow hornet over here. And then this is the paper wasp. How about this guy? Anybody go to Irmo High School? Yellow jackets. These are the most aggressive. The yellow jackets will just kind of sting to be mean, it seems like. And they get very aggressive in the late summer and when it's dry and there's not much food or around for them. Okay, so Hymenoptera. Most people get local swelling and pain. About a quarter of people get large local reactions. We get swelling at the site. And maybe like 1 or 2% will get IgE-mediated reactions of anaphylaxis. We diagnose with history and either a skin test or you can do an IgE level. It's pretty good now. But the skin test is still considered the gold standard. And this is a good board question too. When you see a patient who has a reaction to an insect sting, you only skin test if they have a severe systemic reaction. If they have a large local reaction or even just a limited cutaneous reaction, you don't have to do testing because most kids are going to go on to outgrow these very mild skin reactions or the large local reactions. Now, if someone has a severe reaction with airway, asthma symptoms, GI symptoms, or cardiovascular symptoms, they should across the board have testing, and then anything that is positive in that test should then be given for immunotherapy for 5 years. Also, for very severe reactions, you may check a baseline tryptase level because more and more we're seeing patients with life-threatening reactions to Hymenoptera. They can have mast cell disorders like a mastocytosis. So especially in adults, if you see a patient who just gets stung by an insect and just like drops immediately with hypotension and passes out, we think mast cell disease. Okay, any questions on the Hymenoptera stings before we move on? Okay, and again, it's a
Dr. Amaral, can I ask a question?
Yes.
So, my understanding, if I'm remembering right from medical school is that steroids were thought to like blunt that secondary response. So if you have a patient who comes in and has an anaphylactic reaction, do they need to be admitted for observation then if you don't give steroids?
Yeah, so really good question, and we don't know. So that whole thought about steroids reducing the biphasic reaction was all just conjecture. There is no data that steroids reduce the biphasic reaction. So if someone has, I would say, mild to moderate anaphylaxis, they should be watched for 4 hours. And there's actually some modeling where they say that, you know, after 4 hours, the chance of severe anaphylaxis in a biphasic reaction is less, still possible, but less. But if someone comes in and if they need more than 1 dose of epinephrine, if they have severe asthma, if they were really hypotensive, if they passed out, anything bad, you should watch them overnight. But again, for most patients, it's okay to watch them 4 hours, just in the emergency room observation, even your office, if they're doing okay, and then let them go. But again, life-threatening reactions or more than 1 dose of epinephrine, I give them ideally overnight. And the only thing that we think helps the biphasic reactions is actually early epinephrine and adequate amounts of epinephrine. Okay, so great question. Okay, so next patient is a 16-year-old girl, and she has dinner. Her brother is sick. Little brother's got an ear infection. She's babysitting for the night, and then she puts him to bed, gives him his medicine, and as she's walking down the steps, she gets itchy, hives, short of breath, and she actually trips down the last 2 steps. Her mom brings her to the emergency room, and she has low blood pressure and wheezing. She has IM epinephrine. She gets 0.3 milligrams and does better. And then she recalls a story and said that she gave the medicine. She licked a little bit off of her hand where it spilled. It's good, you know, she was going to wipe it off, and she kind of thought it was like food. And then about a year ago, she developed penicillin-induced hives. And then she had penicillin skin testing, was positive. So for medications, antibiotics are probably number 1, the beta-lactams. Also, we're seeing it more with biologics, NSAIDs. It's pretty rare that we see insulin now. I see it, I mean, every few years at most. It used to be more common when it was bovine and porcine insulin, but now it's all recombinant. Another board question. Some diabetics on NPH insulin can have a reaction to protamine. We don't give protamine much in kids, but it's used during cardiac surgery. Also during general anesthesia, we can see reactions to neuromuscular blockers, antibiotics, thiopental, etomidate. So antibiotics, the most frequent cause of inpatient anaphylaxis. Now, unfortunately, the only drug we have good skin testing for is penicillin. But we do skin testing with what's called the major determinant, penicillin, and then the minor determinant, which we don't usually make them all anymore. It's a pain to make them. But we also do fresh penicillin G. And then if you have a history with positive skin test, you have to either avoid that medication, or you can perform desensitization, where you put them in the hospital and give them increasing doses over about 6 hours. But most patients actually outgrow their drug allergy over time. And the vast majority of people who report a penicillin allergy or any drug allergy don't have the allergy at all. So in studies, about 10% of people that are admitted to the hospital, especially adults, report a penicillin allergy. Of those, maybe 1% of patients actually have a drug allergy. And I can't even tell you the last time I saw a true IgE-mediated penicillin allergy. So what I normally do instead of skin testing is I'll just get a good history. And if it's over a couple years ago, if it seems low risk, I'll just give them the amoxicillin and watch them, and I'll just skip the whole skin testing. So you get about 10% report a penicillin allergy, but well under 10%, probably like 1% have a true allergy. And it's been shown that by having a label of penicillin allergy in your chart is associated, especially in adults, with increased healthcare costs, longer hospital stays, and increased infections like C. difficile, vancomycin-resistant Anacoccus, and then MRSA. Now, penicillin allergy can be due to the beta-lactam ring, but oftentimes in Europe, it can be due to the R side chain. So like amoxicillin in Europe is more often a side chain than it is the beta-lactam ring. And we think cephalosporins are almost always the side chains and not the beta-lactam ring. So there's probably very little cross-reactivity between cephalosporins and penicillins, except that some cephalosporins will share a side chain with amoxicillin, and then some will share a side chain with ampicillin. I think ampicillin shares a side chain with cephalexin, and then I think that amoxicillin shares a side chain like with Duracef, which we don't use very often, and one other. Now, skin testing is very sensitive. One problem with skin testing, it's not very specific. So this is why I only skin test when I really think they're going to have a history of an IgE reaction, because only about half of skin tests that are positive are truly allergic. Now, if you truly have a penicillin allergy, the old data said about 2% of those may react to cephalosporins. It's controversial. So if someone really has anaphylaxis to a penicillin, you want to be careful with the cephalosporin. But what I would do in them is just give them a graded challenge or an observed challenge to make sure they're okay. And if it's an emergency, if I see a patient who has a penicillin allergy in the chart and they come in with meningococcal meningitis, I'm just going to give them ceftriaxone. I'm not going to worry about it. Skin testing is very sensitive to penicillin, but again, not very specific. And then what I do is once we skin test, I just give them a full dose of amoxicillin. But more and more now, I just give amoxicillin right off the bat and see how they do. Like I see kids all the time that they come in, they had an ear infection, probably viral. They took amoxicillin. 7 to 10 days into the course, they get this morbilliform rash, and it was never a true amoxicillin allergy. So on these patients, really try to get a good history to see then who you can take this penicillin allergy label away from them. Because it's amazing, I've seen this last for life. We see 80-year-olds who haven't gotten penicillin in 80 years because of a misdiagnosed morbilliform reaction when they were kids. Okay, another thing to keep in mind for drug allergy is that not all drug allergy that's life-threatening is IgE mediated. So whenever you talk about drug allergy with patients, you have to bring up the severe non-IgE mediated drug allergy. And these are called SCAR, severe cutaneous adverse reactions. And there's 4 of them to worry about: DRESS, drug reaction with eosinophilia and systemic symptoms. This is oftentimes due to the anticonvulsants. They used to call it anti-hyperconvulsant syndrome, or sensory hypersensitivity syndrome. Stevens-Johnson's, TEN, serum sickness, and I've never seen it, but acute generalized pustulosis. Also, it's pretty rare to see true serum sickness now, much more likely to see a serum-like sickness. But at some point, you'll probably see one of these first two. For SJS, we're thinking about TMPSMX, or Bactrim, or Septra. Also, allopurinol, especially in adults. Those are the 2 leading causes. But I've seen it with vancomycin, I've seen other drugs. And then DRESS, again, the anti-epileptics, as well as some of the HIV meds for both of these. And there's actually some patients, especially Asians, have much higher rates of reactions to some of the HIV meds because of some HLA haplotypes. Okay, so moving on. Now you had a 16-year-old girl, and she's had 3 episodes of anaphylaxis with itching, shortness of breath, severe diarrhea, and they all occur at like 1 or 2 in the morning. She's in the Boy Scouts, which they do now, and she's out hiking. She's in the woods all the time. She's normally a vegetarian, but sometimes she kind of splurges and has like, you know, a burger or something. So remember in your board questions, whenever they give you something, there's probably a reason for it. So, you know, why would you say she's a hiker, you know, mostly vegetarian? So any ideas of what I could be leading at here with this girl? Okay, it's kind of weird, we're seeing more of it. So you can have an allergy to the carbohydrate in red meat. So it's a non-mammalian red meat, and it's called alpha-gal, or galactose alpha 1,3 galactose. Your skin test is normally negative to beef, but you can have a positive IgE level to sometimes the beef, but again, more of this alpha-gal. And it's pretty rare because almost always food allergies due to a protein. One of the few times is due to a carbohydrate or this galactose molecule. And you acquire the allergy through the bite of the Lone Star tick. It's pretty cool. So you get these tick bites, you get sensitized, then you get delayed reactions. Another rare thing, up to like 3 to 4 hours after eating red meat, you have anaphylaxis. Or it can happen immediately after cetuximab, which is used for things like colon cancer. Lone Star tick distribution. So especially, it's really prominent in Virginia and North Carolina, but we do see it in South Carolina too. Children oftentimes have a mild case with hives, and it's thought that your body has to absorb the lipids, and then you have the reaction. That's why it's delayed. Fattier meat oftentimes have worse reactions. But so if you ever see a patient who has delayed anaphylaxis, like 3-4 hours after eating red meat, oftentimes in the middle of the night, think alpha-gal. Whereas typical food allergy happens within an hour, at most 2. Every time you eat it, should happen reproducibly. We're seeing it in about 6 or 8% of children, but a lot of kids outgrow their food allergy, especially milk and egg and wheat and soy to be outgrown. Whereas things like peanuts are outgrown 20% of the time, tree nuts 10%, seafood probably 10%. And once you have food allergy in adults, it's oftentimes lifelong. But we don't see food allergies often in adults, for maybe 2%. Adults, shellfish number 1, also fish, tree nuts, peanuts. Children, again, milk, egg, peanuts, fish, tree nuts, soy, wheat. I forgot to add in sesame. So sesame is the big up and coming one. So a food allergy, you diagnose it, the history is key, and then you want to confirm your history or exclude food allergy by doing either skin prick testing or IG levels. But you don't want to overuse these tests. I see it all the time. People come in, I won't name names, but some groups in town that just do these panels of blood work. And then they get back like 4 or 5 tests that are positive. They tell the patient to stop eating the food, and it's ridiculous. You know, if you eat the food and nothing happens, you are not allergic. So these tests have a very good negative predictive value, but a horrible positive predictive value. And the only way to really confirm it is to do an oral challenge. So you see these patients and they're, have eczema and they're avoiding, all these foods. And then you just got to, add the foods back in. But we think avoidance is actually harmful because if you avoid a food too long, you may actually get an allergy to the food. So once you're tolerating the food, you just want to keep eating it. Another thing on this is that early introduction is key, which I've talked about before, but we think that in kids between 4 and 6 months of age, we start peanut in a safe manner. You either peanut butter or peanut powder or these little Bomba snacks. I start eggs early. I start yogurt early. There's really no food you can't start, before the age of 1 due to food allergy. Now things like botulism and choking hazard are different, but in terms of food allergy, you can start pretty much everything between 4 and 6 months of age. And we think it actually leads to less food allergy. So exercise-induced anaphylaxis, we're not sure why it happens, but this is one of the ones that doesn't happen every time necessarily. Some patients have anaphylaxis just occasionally with exercise, or every time they have really intense exercise. And then the food-associated exercise-induced anaphylaxis, it occurs within 2 to 4 hours of ingesting food, oftentimes wheat. I've seen it with shellfish. And then exercise, it can happen. And again, NSAIDs and alcohol can worsen this. So it may take 2 cofactors to really bring it out. Okay, so a 16-year-old patient is having an abdominal CT scan for a possible mass. The radiology wants to use oral IV contrast, but he says that he has a history of shrimp allergy. Okay, so what do y'all think about this? Are you worried about any allergy here? Do you do something different? Is it increased risk?
Doesn't the shrimp allergy put her at a higher risk for IV contrast?
So maybe, but the big story is no. So there's no cross activity between shellfish and contrast. It's not due to iodine And then a shrimp allergy isn't due to iodine either. A shrimp allergy is due to the tropomyosin protein. And then we think that the reaction to the contrast is normally a direct mast cell release. But people that are atopic may have an increased risk of reaction to contrast. So you can say that, yeah, you're right. Any food allergy or any ATP in general, you may have increased risk of reaction to contrast, but it's nothing to do with shellfish. It's a big myth, you know, but people still ask it for some reason. I don't know why. You can have an IgE mediated allergy to contrast, but usually that is not likely. The most common reaction is a delayed exanthem to contrast. You get this morbilliform rash like this. But you can also have urticaria immediately due to mast cell release. Now, this is kind of controversial. We used to give radio contrast pre-treatment with prednisone and antihistamines. The new anaphylaxis guidelines are really not, recommending this. So for most patients, if you use a different low osmolar dye, it's usually fine. So we're not really pre-treating like we used to. But if someone has severe anaphylaxis, they have to get the infusion. We can give it, but we're giving this pre-treatment less and less. Okay, so last one. 18-year-old girl has hay fever, allergic rhinitis. She started allergy shots 4 months ago. She gets an injection. 15 minutes later, she has itching, hives, shortness of breath, lightheadedness. So allergen immunotherapy, before 2002, you had about 1 fatal reaction every 2 million injections. It's actually gone down. There was 1 death between 2008 2012. And then you can have adverse reactions, maybe like mild systemic reaction, local reactions, but anaphylaxis is pretty rare. Now, saying that, we did have a patient not long ago. He had a reaction about an hour afterwards, and he had a really severe asthma attack. He was actually intubated in the unit for a couple of days. It's really scary. I felt terrible for him. So it's certainly a high risk relatively. So whenever you see a patient who's on immunotherapy, if you give it in your office, make sure you ask him, okay, how are you feeling? Have you had reactions recently? How's your asthma? If your asthma is not controlled, you should not be getting your immunotherapy injections. And if they're having a cold, they're a little bit wheezy, tell them to wait, treat the asthma, maybe in a week, see them back. Because this kid almost died. It was really scary. He was on high oxygen and PEEP for several days. You should not get injections at home. There are some groups that do this, but it's not recommended. The groups that do give injections at home, it's usually basically placebo. It's such a low concentrated solution is not going to cause a reaction anyway, but it's also not going to help their allergic rhinitis. So it has to be given a place that can treat anaphylaxis. Again, if they've had recent severe reactions, unstable asthma, beta blockers are actually, we don't know if beta blockers truly cause reactions or not, or worsen reactions. I think we'll probably, let me see, check one thing real quick. Okay, looks like clinic is starting up. So what I'll do is I'll just briefly sound on latex. This is a latex reaction. It's really rare to see a latex allergy these days because we don't have many gloves, and it's usually the dipped products that cause latex allergy. So gloves, balloons, and condoms. And there is no FDA-approved skin test, so you can do an IG level to latex. But again, we don't see anaphylaxis very often. More often than not, you can get a contact dermatitis due to the chemicals that are in latex, and that's a delayed rash. But people that are high risk for latex allergy are spina bifida, but now kids with spina bifida have latex-free everything. Healthcare workers, we don't use latex anymore much, and industrial workers who work in latex are still high risk. Okay, and you can have a cross-activity with latex, with kiwi, chestnut, banana, avocado, potato sometimes. Okay, so that's it. Out of time. Any last minute questions about anaphylaxis? Okay, well, enjoy it and y'all have a great day.
Thank
Bye.
you.
Thank you.
Oh, you're welcome.
Thanks, Dr. Emerald.
Oh, you're welcome. Bye. See ya.